Hi, my name is Connie, and you're watching the video on the introduction to the classification of exodeviations. In this video, what I want to do is give you a broad overview of the way in which we classify exodeviations, and then we'll talk about these in more detail in subsequent videos. So as you're well aware, in terms of strabismus, we can either have a latent deviation or a manifest deviation. So the first distinction is whether a patient has an exophoria or an exotropia. Let's take a look firstly at the exophoria. Now, as we've discussed previously, a patient can either be controlling that exophoria very well, in which case they will, on cover test, have an exophoria with rapid recovery, for instance, and they would be considered to have compensated for their exodeviation. However, for other patients, the deviation may be decompensating, in which case the patient is having difficulty controlling the deviation, and generally on covered tests, now you're going to see a slow recovery or a poorer recovery than, of course, someone who is compensated. And for these patients, at times, they may become intermittently manifest when they lose control of their exophoria. Now, aside from diagnosing a decompensating exophoria, we can then take the next step of subclassifying an exodeviation according to whether near distance disparity exists. So whether there is a difference between the near angle of deviation and the distance deviation. So if we have a look here, we have a term called divergence excess for when the deviation or the exodeviation is greater at far as compared to near. We have the term convergence weakness when the deviation is greatest at near versus far. And then we have a basic or mixed type of exodeviation when near equals far. And so this is the next classification system that we have in terms of exophorias. So we could, for instance, classify a patient as having a decompensating exophoria of the divergence excess type. And what we're saying in that sentence or in that diagnosis is that that patient has an exophoria that they're having difficulty in controlling that is larger in the distance as compared to near. And the point I make down here also is that in order for a patient to be classified a divergence excess or convergence weakness exophoria is that the difference between the deviation at near and far needs to be at least 10 diopters or more. Okay, let's move on to the exotropia. So here we have a primary exotropia, secondary exotropia, consecutive and residual. Now, a primary deviation is one that's generally idiopathic in nature, and it doesn't have an underlying cause for why that exodeviation has developed. Secondary, on the other hand, is the opposite of that. There seems to be an underlying reason for why the exodeviation has developed. A consecutive exotropia is one that occurs post-operatively. And the word consecutive means that the deviation used to be an ESO, and now there is an exo, so there was an overcorrection. So when you hear a diagnosis of consecutive exotropia, it means that there was an overcorrection of an ESO deviation through surgical intervention. And finally, we have residual. This is also a term related to a post-operative outcome, and just as the term suggests, this is a patient who had an exodeviation preoperatively. The patient has been operated on, and now they still have an exodeviation, so they have a residual exotropia. Now, if we come back to the primary exotropia, there's a further subclassification. A patient may have a constant deviation or an intermittent deviation, and most commonly, patients with a primary exotropia have an intermittent exodeviation. And when they have an intermittent exodeviation, generally they'll be classified as divergence excess, convergence weakness, or as having a basic deviation. And these terms are exactly as we see here, in that divergence excess always indicates the deviation is greater at far as compared to near. convergence weakness is always indicating that the deviation is greatest at near, and basic is always a term indicating that the deviation is the same or similar between near and far. Now you'll see that divergence excess exotropia then has a further subclassification. I won't go into this now in this video, we'll talk a little bit more about this later, but you can see there that we can then determine whether a patient has a true or simulated divergence excess exotropia. Now this provides you with a broad overview of how to go about classifying a patient, but I want to make a point about determining the near distance disparity. So here we have the terms divergence excess, convergence weakness and basic. These terms can be applied to all types of exodeviations. For example, a constant deviation may be such that the angle of deviation is greater at far as compared to near, which means there is a divergence excess pattern present. The reason, however, that I've only, or many textbooks also, indicate divergence excess, convergence weakness and basic in relation to intermittent is because we're indicating with that term in the intermittent patients that there is a distance at which the patient is straight. So with divergence excess, the patient is straight generally at near versus distance where they are exotropic. For convergence weakness, they're generally exotropic at near as compared to far where they're aligned or have an exophoria. And for basic, they're intermittent potentially at both distances. So what you see here in terms of classification is that whilst, yes, I've only indicated on the flow chart that those near distance disparity patterns are for exophorias and intermittent exotropias, you can utilise the term across any type of exodeviation. Okay, in the subsequent videos, we'll talk in detail about the various types of exodeviations, but for now, this brings us to the conclusion of this video. Thank you for watching.